Okay. Great.
Why don't we go ahead and get started? Damiano, there's a couple of seats around here. There's a couple of seats up here in the front. What was he on in? So I want to welcome everyone here to this town hall, State of the Hospital and Health Sciences System. Those of you, I see in the audience, a number of you were here a year ago in May when I did the first of these town halls, and at that point in time tried to share with you some of the observations that I had had in being in the position as the Vice President for Health Affairs of just a few months duration. And then what I'm going to do today is share with you some of the progress, accomplishments, challenges, opportunities that we have as a system, and I think will be somewhat enlightening as to how we're progressing in this particular adventure. And I think what I talked about last year was really a articulation of a rather important, bold clinical mission. And I think I just want to go through this one more time with you today, because I think this is something that does clarify. It's such a university presence for us. It's a pervasive theme throughout our university that we are combining a number of modalities here, outstanding clinical care, health sciences education, biomedical research. And we are utilizing these resources to really focus on the delivery of personalized health for everyone in the state of Illinois, but particularly for at-risk populations, because we have no less than an extremely ambitious goal of moving towards the elimination of racial and ethnic health disparities. So I think that's a very important message to take home from this particular town hall meeting. And the other entity that I think was stressed last year, and I'm going to stress it again this year because it's extremely important for us in our challenges that we face, is that we are representing a integrated health sciences system. This is the University of Illinois has within its health system a number of outstanding health sciences college, all in one footprint. Huge advantage for us. If you look around the country, it's almost not replicated anywhere else. We have within these health science colleges are fantastically talented individuals who do a great job of training and education and research. And the scope and the landscape for these events is within our University of Illinois Hospital, our outpatient center. We have within our system mile square federally qualified health centers, a terrific advantage as we, for a goal of wanting to address health disparities, to be able to have community-based practices that are there serving underserved populations is a real advantage. We have the Veterans Hospital, and we have regional campuses across the health science colleges that really do provide the statewide presence that we're talking about. Now, I think it's probably important to, certainly I think one of the things that's important for me in speaking and addressing the leadership within the university is just to make people aware of the fact that we are an extremely large business. The Illinois Hospital and Health Sciences System represents a very large source of excellence in the University of Illinois, but we do a lot. Within this system, the health sciences colleges train the majority of the physicians, the nurses, the dentists, the pharmacists, and are a major strength and source of pride for the state. We also, are a leader in the way that we address underserved populations. We are a very large financial entity our $1.5 billion enterprise, when you include the hospital and the health science colleges. We have over $2 billion in charge activity between the providers and the hospital. And you have to just appreciate the fact that as a part of the University of Illinois, we're a very large part of that important enterprise. And I don't want to belabor several of the challenges that I had offered up last year, but let me just summarize them briefly. That there was a number, what I felt and our healthcare team felt were challenges to our success. I think prior to the establishment of the Vice President for Health Affairs office, we had a little bit of a confusing governance. The head of the hospital reported to one university leader, the head of the College of Medicine reported to another. There was no oversight for either. So not surprisingly, this led to a lack of a very cohesive strategy and vision. And again, as a consequence of that, I think our performance, if you look very objectively at the performance of the system over the past 2 decades, it's been slow but steadily going in the wrong direction. And we've had opportunities of obtaining substantial state support. Obviously that state support is ever at risk, particularly in today's economic situations. And when that was combined with some perhaps not so enlightened decisions around whether to continue to expand our Medicaid strategy, a population and an insurance group that, as a provider for care for Medicaid patients, we enjoy much better than most rates. So, that was an unfortunate, but also part of the challenges that we had as a health system. And just to finish this list out, I think another issue that was very apparent as we sort of peeled back a number of these sort of metrics is that accountability was an issue for us as a health system. And those sort of parameters, and combined with the things that I was mentioning before, are reasons that we haven't enjoyed the sort of recognition as an academic health center that I think that we deserve, but we haven't been so good at pushing on the metrics that allow us to be competitive in that particular field. And our interactions with the community, while the Mile Square has done a fantastic job of interacting with the community, we've had some glitches, and that's caused us some slippage there as well. And all of these things sort of led to the fact that among our academic competitors, the other academic centers in Chicago, our name recognition was not very high. And what was particularly alarming, it wasn't very high even in our primary service area where we do address at-risk populations. So I think that if we talk about some of the progress that I'm about to share with you, it is focused along those themes somewhat. Obviously there's a lot more work to do here, but I do want to leave you with a sense that we are making some progress here. So if we just take the aspect of this of community engagement, I think that we've actually had a lot of success in the last year of pushing towards increasing our community awareness, our community engagement. We've done this through marketing specifically to our primary service area, and with a very large focus for the at-risk populations that we take care of. We've been very much a presence in the community through a number of health fairs and activities that are designed specifically to allow an increased awareness of the fact that we are in the community. We're here with this mission that I've just shared with you, well articulated, well embraced, and one that we are that is designed specifically to address health disparities. So I think that we've made a lot of improvement, and very soon I'll show you some slides where when you look objectively at this, I think we've had some success there as well. The other issue is that from a financial point of view, and this talk isn't solely about what's the financial viability and stability and vitality of the health system. But I think it's important just, again, to underscore a point that was made previously, and I've made in a number of other venues, is that if you look at the last 15 years or so, certainly since FY '99, when the Hunter Group, which came in because of large deficits within the hospital, the Hunter Group came in and, in the typical way the Hunter Group does, he slashed a bunch of jobs and reduced expenses. And since that time, the margin, the hospital net income over that period of time, certainly for the last decade or so, has really been around the $4 to $8 million range. In 2010, I have to say, the asterisk reflects the fact that in that year, we had a lot of, a much larger increase in our net income. But when you factor out the fact that that was due to the furloughs that we unfortunately experienced in 2010, the reduced capital expenditures because of that, the freeze on hiring, all of those one-time payments made by the state to the system, and you factor those one-times and the furloughs out, again, it falls in that $4 to $8 million range. In FY11, we were on our way to about a similar $6 million range. We had a very strong second half in FY11, so we finished out close to 10. In FY12, we had a very nice $14 million increase, $14 million margin that was the highest that we've had in the previous 14, 15 years. And even with a lot of challenges that I'll go into detail, and you factor in those challenges for our FY13 projections, we're anticipating to finish around a $15 million margin. And that sounds great, and it is great, but the fact is that we have a lot of room for improvement. And the reason I say that is those arrows are pointing to a 3% operating margin target. Again, if you talk to any healthcare economist, they will tell you in order to be sustainable, you need to achieve about a 3% margin. And if we're a $750 million hospital, that's about a $20-25 million margin. And that's something that we need to shoot for, and we really need to have plans and a strategy on how we might get there. So there's also a very alarming, over the last few years, certainly from FY09 to 10 to 11, there's a very alarming decrease in our average daily census. If we, and obviously this is a major driver to the bottom line, so this is a very alarming situation. Again, we had a series of activities that we were hoping would improve that, and they actually had success in reversing. We were on target to go down to about 300 with an average daily census of about 300. We finished about 310 in FY11, and in FY12 we were about 322. So that was a very, very nice reversal of this decline. And again, we have some aspirations of breaching the 330 mark in FY13. And again, this is so important because even though a lot of medicine today is moving towards an outpatient-based delivery system, this is a major driver to the financial health of the overall enterprise. And so the trends are good. And again, we have additional strategies that we're employing to not only to try to achieve this goal of 330, but to increase it even beyond that. I don't know why I have to click so many times for it to change here. So if we look at a summary of where we were in FY12, a big reason that we've had an increase in our average daily census, a big reason that we've had this bump in our financial parameters is that our clinical volumes have increased. And I salute all the health science colleges, and I salute the department chairs that have worked so hard. And I think over the last year we've had many meetings to try to absolutely be on the same page and moving programmatically and strategically towards mechanisms on how we would increase this book of business, and I think it has been very successful. And again, I applaud all of those individuals for helping push us in this direction. So we've had an increase in our the physician RVUs, which clearly is a reflection of increased activity, productivity, and work. We've had an increase in our clinic visits. The number of operations that we have done has increased almost by 10%. I've already shared with you our average daily census and our admissions. And our ER is even busier. Our ER has had a 4.5% increase in ER visits. And very importantly, is that a major metric of quality is the fact that the percentage of folks that have left without being seen. This is a metric that's followed all across the country. At the University of Chicago, for example, this is well over 10%. We've had a 4.5% increase in emergency room visits while having a decrease in our left without being seen to around 3%. Really remarkable job by the Department of Emergency Medicine and the staff there. So, like I said, we had several strategies. Complementary and Camille Baxter and our marketing groups did an unbelievable job to try to address this low consumer awareness. We've had a complete overhaul and continue to be overhauling the website even as we speak here. So, but the website's much more consumer friendly, much more informative. Did a great job there. We have a lot more hits on the website than we ever had before. And diving deeper into the information provided by the website, we have lots of metrics of increased access and spending time on the website as well. We've taken our marketing launch, which was earlier this year. So we had a marketing launch with the University of Illinois Hospital and Health Sciences System that began in February and really picked up more speed in March and April. And we're still going through the next phase of that even now. But the bus shelters and buses and ads and print ads, et cetera, as well as some sponsorships with Chicago Fire. We had an employee recognition night at a Chicago Fire game. As many of you know, Chicago Fire is the pro soccer team here in Chicago, and it has a very, very large Latino population that follows soccer there. And that was a really wonderful time to show some appreciation to the staff and faculty here here within the health system. So what's been the effect of this marketing and launch? Well, we use YouGov.com as a mechanism for obtaining and querying folks within and without outside of our primary service area. And so I'm showing you here on this graph familiarity with our former name, the University of Illinois Medical System, and our new University of Illinois Health in our primary service area. And I think what you can see here, you can see on the sixth set of bars there is the University of Illinois Medical Center. What you can see is if you look at the observation points of November 2011 and February 2012, we ranked about 4th among our academic medical competitors, and I've thrown in there Mount Sinai as well. And so we ranked 4th among the 6 of these hospital systems. But if you look at May of 2012, again, just a few months, maybe 3 months after we've started the marketing launch, you can see in these graphs that, in fact, the University of Illinois Medical Center, and we asked half the respondents to pit UIMC against the other hospitals, and we asked the other half to pit UI Health against them. And you can see we've made a lot of progress, and so we were the top with familiarity compared to our academic competitors here. And when we queried about UI Health, it was actually 71% of the respondents said they were familiar with this. And what's important as well is that we had a 20% bump in our perception index score, and this reflects the willingness to recommend as well as our reputation. So this is very, very, very strong evidence, and we were very, very gratified by that. And then finally, one of the other questions that were asked is that comparing to the health systems that are shown on this particular bar graph, who do you think has the most community involvement? And by that, we led by a substantial margin. So that actually, I think, was gratifying that, in fact, some of the word is actually getting out. And so we need to continue to follow these sorts of metrics to see whether we're continuing that and perhaps improve for sure. This is really irritating. Another example of success, we've continued to be one of the American Hospital Association's most wired hospitals. That's something that we've done several years, the 6th year, for example. And what this is a testament to ADDRESSIN and his shop. This is really a lot of hard work goes into this, because implementation of all of the quality, patient safety, practice integration, all of these modalities that run through the IS and IT system are challenging. They're expensive and challenging, and it's really gratifying to know that we've gotten this sort of recognition. So another thing I wanted to just share with you is the idea that we've, in looking at how we're going to approach improving our overall enterprise, was a specific focus on improving our business practices and analytics. And so we engaged. We knew that there was absolutely a tremendous room for improvement in our billings and collections. We previously had the hospital doing billings and collections with one entity with a lot of challenges and modest efficiency. We had providers like the College of Medicine using a separate system, separate group of individuals to do billings and collections with even less success. And so right now we're in the process of doing a revenue cycle integration. I think this is going to pay very large dividends. We're early on this, but we're moving to electronic charge capture. This is going to be very, very big. We have way too much paper billing and handing off of data, which leads to mistakes, leads to delays, and I think we're moving very, very nicely towards a much more electronically integrated fee schedule, billing, and collection. And the overall impact of this, which is important, is that by doing these interventions, the overall value to the enterprise has been suggested conservatively to be in this neighborhood of $70 million over the next 10 years. So another feature I wanted to share with you is one that was spearheaded by Brian Becker and a number of the teammates within the call centers there, is IPAL. So Illinois Provider Access Line. So as you might think, some of the prior challenges for referring physicians has been a lack of communication with our docs, a lack of central contact and getting accurate information about who's on call, who's not on call, the accountability surrounding transferring of patients or referring of patients to our system. And then the problem was we couldn't really track when we had patients being transferred from other entities. So this is a dedicated attending to attending line. As you can see from this particular schematic here, a physician calls up using this one number throughout the state, calls this number, it's answered, and you have a transfer center nurse on the line that follows the conversation. Within 20 seconds, hopefully down to 10 seconds, we have a really quick answer of the ring. We have a quick contact with physicians because we have all their pager numbers, and now we have a physician on the phone within a minute. And so with this, now we are able to monitor the phone call. The physicians talk about the patient that needs to be transferred. They say, okay, we agree to take that patient. The referring physician can hand off to their nurse or someone in their office to provide the rest of the information. The physician on our end can hand off to the call nurse that's monitoring the phone call, and the transfer and all the information for a proper and expedient transfer can take place. This has been, we've seen this at other places that I've been. This works fabulously, and I think this will be a great satisfier for not only our own physicians, but also for the most importantly, the referring physicians. So there's lots of benefits of the IPAL program. We've only done the soft launch right now because we only started it in July. But if you look even in that short period of time at the number of transfer requests, so before February 2012, we never had over 100 transfers to our institution. And then just prior to February 2012, there was an initiative by Fadi Charbel and Terry Vandenhoeks, the Departments of Neurosurgery and the Department of Emergency Medicine, started and initiated a new transfer model, and you can see that's had very, very large success. But then if you look where IPAL actually got implemented here, we've actually had our highest numbers of transfers over the last month or two. So this is, I think, a very important part of providing better service to our referring docs. The other thing that we've done is we continue to expand our telehealth programs. We obviously serve the Illinois Department of Corrections and particularly around HIV and hepatitis C. This has been a very well-run program, and we were looking to expand that. We've also expanded from the Department of Otolaryngology to providing telehealth in Rockford. So this is a new program for children and young adults, and that's been increasingly successful since it was launched several months ago. We are in the process of implementing the telehealth services across our entire Mile Square community. We're starting slow. We have a grant that funds ENT, mental health, cardiology, dermatology, nutrition. These will be the foci of these telehealth entities and allow primary care access to subspecialty care from distant sites, and that obviously will be very important and useful for consumer, for patient satisfaction, but also delivery of better care for the community that's being served in those locales. And then finally, telestroke and teledermatology. The telestroke program is continuing to prosper, and I think these are, again, other evidence of our interest and appetite to expand these particular services. So this is a shot from the annual report when I was the Vice Chancellor for Research, and I think I just wanted to remind folks that one of the outcomes when we had surveyed the University of Illinois at Chicago campus was that there were several very clear themes of excellence that existed within our University of Illinois at Chicago's research portfolio. And one of those three was community disparities. And I think what we're very interested in doing, showing, as I've mentioned within our clinical mission, when I stated that with the second slide of this talk, you know, and the Mile Square Health Centers, again, is a very dramatic and important demonstration that we are about addressing community disparities, particularly the health disparities that exist in the communities around us. Mile Square, I don't think everyone actually knows that they are a deeply integrated part of the University of Illinois Hospital and Health Sciences system, and the fact that they are in more than half of the communities that are in Chicago. They provide many outstanding services and lots of encounters for the patients that are at risk and also are medically underserved. And we're very excited about the fact that we've been able to, with Henry Taylor's leadership, been able to get a grant of $12 million and leverage additional resources to be able to build a 5-story Mile Square facility on the corner of Roosevelt and Wood Street. And I think when this facility is done, the first 2 floors will be Mile Square. We'll have dentistry in Mile Square as well. We'll have a lot of opportunities of being able to provide for folks within our community at a terrific facility, and that will have a lot greater access to subspecialty care. And so we're very excited about that, and that is moving through the system right now and planning for a December 2014, something along those lines. Maybe, yeah. Heather says maybe. Okay.
Nice and better.
Oh, better be. Okay. That's even better. Okay. Okay. I guess he really likes this picture here. I don't know why. All right, Neil. Well, there we go. Of course, you just had to get you out of your seat there. And I think one of the things about Mile Square, and I think one of the things that we're very excited about within this past year has to do with the community of Englewood. I think some of you may know that the city made a decision to close 7 city clinics a while back, and created an opportunity for a competition to contracts to serve the city clinics that were being closed. And I have to say that we had a presence and continue to have a presence in Englewood. We have a strong prenatal care midwife program there, women's health program there. And as you can imagine, Englewood is unlikely to be a large source of revenue for the system, but we very much believe that this community does fit our mission very much. So we, in a very competitive application led by Jerry Christian and the Population Health Science team within the VPHA office, we were successfully awarded this, and I can tell you that this has been a very impactful thing for this community. The sense of abandonment by this community when the city decided to close it was palpable, but also equally palpable is the excitement about the University of Illinois being part of that community now. And so we had an opening there on open house on October 4th, just last week, and it was attended by Congressman Diana Davis, who you see in this photo with Henry. It was attended by 5 aldermen, 2 state senators, and many people from the Englewood community. And I can just tell you that we received lots of kudos for our commitment to addressing disparities in this very direct and meaningful way. And again, hats off to Jerry and Henry and the rest of their teams in being able to operationalize this, because that was a very big challenge, particularly with the city peeling off. But our visits to the clinic are ever increasing, and they're higher than they were before the close of the clinic. And so we're excited about how this is going to be part of our overall plan for addressing disparities in Chicago. Yeah, Neil, you're going to have to stand up again. Another program that I wanted to share with y'all is a program that was spearheaded by Terry Vandenhoek as chair of the Department of Emergency Medicine, and this is Illinois Heart Rescue. And this is a program around increasing bystander CPR rates, which are, abysmal in Chicago, and the target here is to increase from less than 10% to over 30%, and to increase the number of resuscitated cardiac arrest patients to over 20%. And in Chicago, that number is around 4%. Other cities in America range between 15 and 30% with that, and Chicago is extremely low. So Terry, with his colleagues, wrote a very statewide, comprehensive program to increase awareness, increase training for CPR, and with a specific target on vulnerable populations, because obviously those are the groups that have the highest arrest and the lowest success in resuscitation. And so this is going to be a very impactful program, and one that was led by with partnership with the University of Illinois system here. So I also mentioned that we were very interested in delivering personalized health to the folks of Illinois, but particularly at-risk populations. I think obviously the poster child for these events and initiatives surround the disease of sickle cell. Our university and our health system has had a strong focus and a commitment to serving patients with sickle cell disease, and that's been evidenced by the fact that when a lot of other institutions were sort of closing down on the number of government-insured patients to their hospitals, we actually opened a sickle cell center here at the University of Illinois. This is a disease, as many of you know, is a single mutation in the beta-globin gene, which reduces the lifespan of the erythrocytes, particularly during infection. And that reduction and change in the morphology from a normal RBC to a sickle RBC is what causes the sludging in the vasculature and produces many of the complications of sickle cell disease, as you can see on that slide here. Well, we have a very strong, comprehensive program to address this particular disorder and the complications of sickle cell disease. Victor Gorduke and Louis Suve from medicine and from pediatrics, and the very dedicated team in the Sickle Cell Center have really done a spectacular job in building programs around the clinical trials involved in sickle cell disease and the monitoring of sickle cell patients and the application of novel therapeutic and diagnostic and prognostic sort of markers. And Victor put this in, put a very strong U54 application to establish ourselves as a center of excellence in sickle cell disease. It was a spectacular application, very genomic and genetic in focus. And we have papers like this coming out from our colleagues that show that we've now gotten to the point of identifying through blood gene expression testing signatures within these genes that predict pulmonary hypertension or address pulmonary hypertension in patients with sickle cell disease. So this allows us to have a greater understanding and subphenotyping of these patients for clinical therapies. Now, one of the clinical therapies that you would think would be really successful in sickle cell disease, because it's a red blood cell issue with hemoglobin, that it would be a bone marrow transplant. But the fact of the matter is, when you do a bone marrow transplant, you have to radiate the patient and you have to provide them high-dose chemo to ablate the bone marrow. As it turns out, and so as a result, when you do that in sickle cell patients, they do not tolerate the high-dose chemo or the high-dose radiation. They get lots of toxicity and an infection, and folks have quit doing bone marrow transplants in sickle cell disease. But our folks here, Damiano Rondelli, working with the sickle cell group, and we're able to figure out how to ablate the marrow mildly with low-dose radiation without chemo when you used a matched sibling. So they did their first bone marrow transplant, stem cell transplant in a sickle cell patient last November. And I think some of you may have remembered in the very large press that we had around this, the fact that this transplant from a sibling had provided a cure for this patient with sickle cell. So if you look at the hemoglobin in this patient, it's all normal hemoglobin, no evidence of the sickle cell. So this is unbelievable. And we've done 3 patients like this so far. Damiano says he has a number of folks lined up in the clinic that are being evaluated right now for additional stem cell transplantation. And I think this is the kind of cutting edge work that we should be doing here and are doing. And I assure you that not everyone in the country is really focused on trying to figure out how to cure sickle cell disease. So I think we're in a very, very small company in that regard. Now, the other thing about the stem cell transplantation is that I wanted to just share with you the fact that, again, last week was a big day for opening dedications and open houses and stuff. And so we had the opening of the remodeled bone marrow transplant unit. And there's Damiano and Jim Perry, who provided a lot of resources for helping do the remodeling of the unit. And this is going to be very impactful because it's a state-of-the-art, spectacular unit that I think will be very helpful for these patients that have a pretty rough road when you undergo a stem cell transplantation. So we're really excited about that, and as obviously the staff in this bone marrow transplant unit are very excited about it as well. So another example, I think, of the application of translational research to improving healthcare in our community is our pharmacogenetic service. This is a service that we started in July, and the focal point for this service surrounds the use of warfarin or Coumadin. This is a blood thinner, as most of you know, a blood thinner in which it's very difficult to figure out how do you dose someone that's starting Coumadin. And the reason for the difficulty in dosing is that there's 2 genes, VCOR and CYP29, that are genes that regulate the metabolism of Coumadin. And there's variations, or warfarin, and there's variations in those 2 genes that provide either a genotype that has that individual metabolizing Coumadin very quickly or warfarin very quickly. You could have a genotype that has very low metabolism of warfarin. If it's low metabolism genotype, of course, you would need a very low dose. And if it's a high metabolism, you need a higher dose. And of course, most people fall in the middle. But you can imagine if you're just guessing on the dose, which is what we do clinically, empirically in medicine right now, if we don't use the genotyping test, you're overdosing a lot of patients, you're underdosing some patients, and that leads to Coumadin being one of the highest drug-related adverse effects in the country. So this pharmacogenetic service, what they do is they do a automatic consultation. You order warfarin, the team shows up, evaluates the patient, does a genotyping of the patient, puts them into one of these categories, and using an algorithm that they've figured out, use that algorithm to dose these patients, and then they follow them longitudinally. And this is a very personalized approach to how to deliver and how to reduce the adverse effects of a blood thinner like warfarin. Now I have to just tell you, so most of the genotypic information for warfarin was based upon genetic variants in non-Hispanic Caucasians. So what Laurie Cavallari and Tom Stamos and Ankit Desai and Bill Gallanter and all the team that comprises the pharmacogenetic service, what we're doing is we're sequencing these genes, these two genes, we're sequencing them in African descent individuals and in Latinos, and by having the information around the variations in these two genes in those populations, we'll be able to have the most comprehensive genotyping test around, and we'll be absolutely the world's expert on how to dose warfarin safely in all individuals. And right now we're the only hospital in America that's doing this, and the reason is that the test, the genotyping test, isn't reimbursed by third-party insurers. This is something that our health system decided that this is worth doing because not only is it providing better care for those patients, but also the length of stay. There's lots of data that shows length of stay and readmission rates are reduced when you do this. So it's a good fit. And our program, even though it's only 2 months old, is getting a lot of notoriety, and we're getting calls from folks like the Cleveland Clinic and in Ohio State to figure out how they might want to implement a similar program at their place. So I think I have one more example here. It has to do with a disorder named sarcoidosis. Some of you may be familiar with this. This is an inflammatory lung injury, lung disease causing fibrosis. But it also not only affects the lung, but it's also found in smaller percentages of patients in heart tissues and in brain tissues. And the folks that have sarcoidosis, many of them get better with minimal therapy, but there's about a third of them that go on to develop very severe lung disease or cardiac disease and neurologic disease that is potentially fatal. And the problem is with sarcoidosis, it's really hard to tell whether you're in that 2/3 of the group that's going to do fine with the disease or the 1/3 that won't do so fine. And so we are now part of a clinical network, an NIH-funded clinical network to study sarcoidosis. And sarcoidosis is an area of health disparities because folks of color have a rougher time with sarcoidosis. Folks of color are likely to have more complications like progressive lung disease and cardiac sarcoidosis and neurosarcoid. And we're coming up with new biological and genomic and genetic insights into the disease. And this is, I think, a very systems biology approach to how we might really reduce the health disparities around sarcoidosis. And we've partnered with the Bernie Mac Foundation. So many of you might know Bernie Mac died of sarcoidosis. We partner with the Bernie Mac Foundation, and they've now are supporting research within the University of Illinois' Bernie Mac Center for Sarcoidosis. And again, like the other previous slides, we had a ribbon cutting last week. And there's Nadera Weiss, who directs this program for us, and Nadera is talking about the problems of sarcoidosis on this Inspiring You. And we had a lot of coverage about it, and it was just a really wonderful event. I think this is going to be a wonderful partnership for us and a way to address health disparities and also think about how to get other funding streams for doing the impactful research that we do at this university. And I just wanted to end this part by saying that, you know, we are really leading the way in how we employ these technologies, these cutting-edge behavioral health, genomic, genetic, and translational research tools to reduce health disparities. We had a symposium that was held here in September that was the first of its kind in the country that was funded by the NIH. And Enrico Benedetti, as many of you know, I can't remember if this is the third or the fourth of the Bridging the Gap symposium that he has, but he also brings awareness of the health disparities and underrepresented minorities. He brings that to the community in a big way during the conference that he has, which is scheduled for November 17th. So let me just address a few issues around service excellence and some of the leadership that have recruited to help us with these endeavors. This is a shot of a dashboard that, you know, every time we have a University of Illinois Board of Trustees meeting, and it feels like it's like every month that we're having those meetings actually. But we have a healthcare committee meeting associated with the Board of Trustees meeting, and at that meeting I present the dashboard, and what this shows is just a very brief snapshot of what our activities are, as you can see with average daily census and some of the other parameters here. But two parameters that are very important for us to follow that we haven't been doing so well on are patient satisfaction scores, both inpatient and outpatient. And so I think in addition, we have metrics not only of patient satisfaction, but also metrics of quality. And you know, this is again the same dashboard that I present at the healthcare committee is in fact around measurements of clinical effectiveness, efficiency, safety, et cetera. And you know, red dots mean you're not doing so well. Yellow dots means that you have room for improvement. And you know, we have a few green dots. But if you look at this, and this is data that compares us to the rest of university hospitals. So it's the University Health Consortium. They pull our data in. They sort of compare us all, and then we can pull our data back out when we're compared to everybody. And we have a lot of room for improvement here, as this dashboard even shows in its brevity. And so in order to really address issues like patient satisfaction, quality, and patient safety, et cetera, we are very fortunate to recruited Erica Steed. Dr. Steed was the Vice President for Professional Services at Advocate. She joined us in July as our Chief Experience Officer. She's doing an unbelievable job putting us plans into play which will allow us to make progress and enjoy substantial progress in improving patient satisfaction scores. We also have recruited Jody Joyce, who starts in a week or two. Jody was the Vice President for Quality and Patient Safety at Legacy Health System in Portland, Oregon. Lots of national distinction around Jody's performance around quality and patient safety, and so we're very excited about her joining us as well. And also starting in November is Jay Rue, who is currently the medical director for Kaiser Mid-Atlantic for probably another 3 weeks. And he's going to be joining us to serve as our Chief Medical Officer and as our Associate Vice President for Professional Practice. And I wanted to say that these individuals, as well as the individuals that I'll show you on the next slide, are the result of a search that we employed, staffed by department chairs as well as clinical science deans that would really participated and put a lot of effort into that, and they gave us some great candidates, and I'm very pleased that we were able to snag the top person in these categories. Two additional people that fall into that very same sort of motif are shown here. Rob Wynn is a associate dean at the School of Medicine at the University of Colorado. He's an R01 funded physician scientist and with expertise in lung cancer. And Rob will be taking on the responsibility of serving as our Associate Vice President for Community-Based Practice. And Rob will start on November 16th. And then Carl Kockendorfer used to be a resident and faculty member here within the Department of Family Medicine. Carl's an unbelievably bright individual that has very entrepreneurial ideas on how to use clinical information and information technology and information systems knowledge to improve the way that we practice medicine. And he's taken on the role starting in January as Chief Medical Information Officer. And we're really excited about having Carl join the rest of the talented group that we have in IS and IT. And we're in our final stages talking to these two individuals, Phil Greenland, who ran the CTSA at Northwestern, PI of the CTSA there. He's a preventive cardiologist and very outstanding, highly regarded clinical trialist and in patient-oriented research. And Lolu Ojo is also someone that may be familiar with some of you. Lolu's a great guy and also a professor of medicine. He's a nephrologist. He's at the University of Michigan. He does health disparities of renal disease in this country and also in several countries in Africa, a very well-funded NIH physician scientists. And so that work is in progress, and I think will be completed relatively soon. So I wanted to end the final part of this with, as I check time here, with some thoughts about some of the local and systemic challenges that we have. Obviously, we've had success. We've I think gotten our arms around a lot of issues that needed attention and some thought and some planning. I think we've done those things. I think we're in implementation phase for a number of them. Clearly, some of the early initiatives that we had that were of vital importance for our system to be successful, which includes increasing consumer awareness. I think those have showed very, very key signs of being successful. But we, I think, also have some sobering aspects to this, because even though we've reversed, I think, a 2-decade trajectory that hasn't been positive, we have a bunch of challenges that some of them are related to us operationally, but many of them are external to the University of Illinois. And they are shown here. You know, I think everyone knows and everyone has felt the fact that, you know, the general reserve funds have been cut. And we have a revenue stream from the state, which one would argue should be not part of a general reserve fund cut, but is. And so that's painful. That, you know, you saw how razor thin our margin is. This is a difficult thing for us as well, and further cuts will only increase the challenge of that nature. Now, Medicaid reimbursements, I think many of you know that the state has undergone some Medicaid reform. That's been an issue, and it will continue to be an issue. Very high on the state legislation and the governor's agenda has to do with pension costs. If pension costs are shifted to the hospital, that will be a substantial increase to the expense of the hospital. Again, keep in mind the very narrow range of our margin to begin with. And as you know, Obamacare and the Affordable Care Act moves into place, I think there's going to be associated changes in reimbursement across particularly Medicare, with many more indices and metrics of quality and performance that will be linked to those that will put us at risk. Chicago is a very competitive environment. I think you just only have to look across the street at the Rush Hospital to know that, you know, it's changing. Lots of places are building new buildings and we're not. And then we have risk around compliance. I mean, we haven't really had a comprehensive approach towards compliance issues, and that is something that is a potential risk, and we need to address that seriously, because that has a potentially dramatic effect on our overall vitality. And you know, the fact is that we haven't had, because of that thin margin that I've shared with you earlier on, we haven't had the sort of resources to invest in our capital infrastructure and in other activities. These are all things that are, I think, very challenging for us. And this slide just kind of captures a few of those. The fact that Governor Quinn, you know, took off $2.7 billion off of the Medicaid expense. You know, part of that was a cigarette tax, so I'm not anticipating he's going to use that same strategy next year. So that's something that we have to be cognizant about. There's a lot of rearranging of partnerships within Chicago, and I think that's something that is, you know, as we move into the Affordable Care Act, is of importance to us as a health system as well. And you know, again, the competition's fierce. This is a very challenging healthcare landscape. So, beginning at the beginning of the summer, our leadership team and President Easter and Chairman Kennedy were meeting specifically around getting some traction on 3 important initiatives that we thought was really important for us to do in the short term to address some of these challenges. And one of them was that we've been burning operating cash to try to maintain our hospital and to try to address some of the renovation and modernization necessary, that is not a very good strategy to be using your operating cash for those purposes. So we've got President Easter's support and Chairman Kennedy's support for moving towards a bond issuance. This we're hoping to get to before the board in November. And this bond issuance will give us some resources to address some of the infrastructure modernization and renovations, as well as a few other projects along with that. And we also have a strategy for expanding the large leasing opportunity so that we can get some of the state-of-the-art equipment we need in order to bolster our equipment needs. And so that is, I think, a very important initiative that we should be following over the next few months. A second area has to do with the importance of us continuing to push on this enterprise integration. And when we talk about enterprise integration, we're talking about having our clinical resources and our clinical leadership all really moving in unison. Because as you think about the issue of being an integrated health system with all the providers that cover all of the dimensions of healthcare, as well as being able to provide a service to a group of patients, you have to do this in a seamless fashion. You have to be ready to negotiate potential contracts with all comprehensive healthcare being part of that. And we have some room to improve on that. But if we can, I think we will be able to more successfully compete for some of these, get improved rates from the third-party insurers. That will be a big boon for us. I think we will improve our quality as we have more oversight and more integration around some of the practice of healthcare that we're delivering. And I think we have an opportunity of moving into markets because as a healthcare entity that has comprehensive managed care, we will be a competitive entity. But we have to do that with looking towards having good competitive products there, which means that we have to be cost effective. And again, that mandates the need for more integration as well. And again, if we do this, I think we can emerge as a robust managed care entity. And the final area that I think is important for us to be moving towards in the short term, I think we need to continue conversations that we're having with other healthcare systems in Chicago and in other locations, because these partnerships I think are important for our overall vitality. And we're having conversations with a number of these, and the conversations are a different conversation than we used to have. So it used to be that we would have maybe a department would send some physicians out in a one-time contract with a hospital or a system to provide a single point of care, and that might be good for the department's physicians, but it wouldn't be necessarily good for the overall healthcare enterprise. And so what we're really interested in now is not really moving down that model. We're really interested right now is providing service lines, and service lines that are focused around a book of business in which we share the co-managed between the University of Illinois and the other healthcare partner. And because it's shared and co-managed, that we have more opportunity of having an impact on our overall healthcare enterprise. And we are having those conversations, and actually they're going very well, and I hope down the road to be able to update you on some of those conversations. So last few slides here. So how do we, there goals for FY13 and 14, we could spend probably 30 slides on what those goals might be. I thought I would just wrap them up into 4 big categories. One is financial goals. Obviously, big on this is the not needing to utilize our operating revenue in order to perform capital improvements. So the bond is going to be very important for us there. I think we want to target towards that operating margin that I mentioned of $25 million a year. I think to do that, clearly, the revenue stream needs to be expanded, the expense stream needs to be reduced, and I think we have a lot of thoughts and initiatives that are focused on both of those entities. And without going into detail, I think we have a very good plan on how to move towards that financial goal. Now, as far as operational goals, I mentioned the strategic partnerships are important. I think we need to actually get some success in landing a couple of service lines with a couple of strategic partnerships in Chicago, or maybe even out of Chicago. This will provide us opportunities of expanding our influence as an academic medical center in our translational research programs as well, to provide additional educational venues for our trainees, something that's very important to our overall mission. And we need to continue to move towards improving our efficiency, you know, our efficiencies in clinic, our efficiencies in moving patients through our system in the hospital, reducing the amount of time it gets to go from the ER into a bed, or the amount of time it takes to get a patient when you know they're going to be discharged out of the hospital. These are all seem like simple things. Trust me, they're not so simple, and we have a lot of people thinking about them. But they're very important, because if you actually can be successful in reducing those sort of metrics, it means that your flow through the hospital is larger, your average daily census improves, and financially it has major amplification. Operations are the same, and inpatient admissions, as I mentioned, we have these targets. I've already shared them with you in a previous slide. The other two big ones are, one of them is accountability. You know, this is around not only the patient satisfaction, but importantly the staff and the physician engagement. You know, we want happier staff. We want physicians to be and other providers to be much more attuned and feeling quality of their workplace. And I think we need to do a better job on this, and we clearly need to be assessing this and utilizing our best practices on how to improve on those sort of things. Reducing our risk through reduction in malpractice. We have some initiatives already in play there. Brian's spearheaded, along with Tim McDonald and others, some issues around that. And, you know, compliance, this is a big nut to crack, and I think, you know, we don't have enough time to talk about that issue right now, but that is something that's very much on our radar screen on how to get a more comprehensive approach to improving our organizational compliance. And then finally, the quality and process improvement goals. You know, we want to be better than we are right now. We aspire to be better than we are right now. And some of the easy metrics in which are easily followed, and not only followed by us, and the important point here is they're followed by the lay public. You know, people can go on the web right now and find these answers for every hospital in Chicago, and we don't look so good. And so we need to look better, and we will look better, and we have, I think, programs to specifically address that. Now, so, you know, here we are. That gives us goals for FY13 and 14. In 2015, you know, of the Affordable Care Act. You know, obviously maybe depending on somewhat on what happens in a few weeks in the election, but inevitably this is something that has been designed to expand insurance coverage. Will that be, you know, how would that affect us? The innovation integration part in addressing health disparities, obviously that's a fit. But when you think about the U.S. and the state healthcare reform, you know, you have to really question, how is this really going to affect the University of Illinois Hospital and Health Sciences system? Well, I can't claim to be this guy who can predict the future, but I do know that if we continue to do the things that we've talked about in this presentation, we'll be in very good position, I think, for meeting the challenges of a changing healthcare landscape. I think the position I would like for us to be in 2015, if I were to say what are our stretch goals, what do we want to really aspire to be in 2015? Well, I'd like for our system to have a large market share. Right now we're probably in the 4% range. You know, so this seems like a very dramatic improvement, but you know, you've already seen consumer awareness improving. The quality of our services will improve, and I think this would be something for us to aspire to. I'd like for us to be evolving as we have the sort of the leadership and the right strategic vision within the organization to be a managed care entity that has statewide reach. You know, statewide reach, given the fact that we're a university with lots of students and lots of faculty in different locations, that should be an advantage. We're not leveraging that advantage right now. We should be a managed care entity where people that work at our hospital and teach in the university and work at the university should want to seek their health care from us. We need to get their confidence and their trust by providing the product that makes them feel like they are going to the best place for them for their health care. You know, again, you know, we're not anywhere on the top 50 of the U.S. News and World Report. I really think in 2015, through a series of targeted and specific approaches, I think we have an opportunity to move into the top 50. I think we have the talent. I think we just need to leverage that and be better at marketing what we do well. And I think many of these reputational scores for U.S. News and World Report are also linked to hospital scores, hospital outcomes. And as we looked into some of these metrics within our hospital, we weren't reporting them quite as accurately as we could have. As we improve on that, I think there's lots of opportunities to move in the direction of increasing academic recognition. And you know, again, despite the woeful state of Illinois' finances, I think for us, we are the state's only university academic medical center. And I think if we can show, like the example we've given here where we're curing sickle cell disease, and curing sickle cell disease, if you think about it, you know, it sounds like, well, maybe this is another application of the high cost of U.S. healthcare because we're using high-tech technology. Well, in a sickler, if you look at the economic impact of curing sickle cell in that individual, it's about $8 million of what you'll spend on a sickler from age 20 to about age 50. And for the cure that we have, it's about $500,000. So over that 30-year period of time. Not to mention the impact on the quality of life, the ability to engage in productive opportunities within the workforce. These are the sort of things that we need to make the case to the state. And if we are cost effective in providing this care, and we are able to make that case to the state, I think that we will be very much somewhat in immune status from the sort of cuts that are being contemplated elsewhere. And I think right now we're well on our way for achieving this goal. Recognized by academic medicine as a leader in personalized care to at-risk populations, no one has the mission that I've just shared with you. No one has that mission. That is our mission, and I think if we are successful there, we will have the academic recognition that not only deserve, but we will be impacting how other academic centers maybe take a page out of our playbook in order to address health disparities in their community. And then finally, again, this might be a stretch goal, but I think if we happen to achieve the top parts of this particular list of things, I don't think it may be out of reach. I think if we can be the sort of financially stable despite a very volatile healthcare landscape, I think we can get to a point where we might actually be breaking ground for an expansion of our current facilities. Anyway, the point that one of the points that I wanted to make throughout this talk is that, you know, we are making a difference, and I think making a difference is absolutely risky business. Sometimes, maybe every day, I feel like this guy. But I think we are making a difference, and I think it's because of the way that we are able to come together as an enterprise where everyone is paddling in the same direction and shares this commitment to this very, very lofty goal. And I think that it will be fun to be able to continue to share that success with you as we move down the road. So let me stop right there. Thank you for your attention, and I'm happy to answer some questions. Yes, please. Hi.
So there's lots of very exciting things to announce there and a lot of exciting opportunities for clinical care and for research. And I'm wondering about the third part of the university mission. So I think a lot of us here think about the mission including not just clinical care but research but also education. And I didn't hear a lot about education. I was wondering where education both at the medical student and nursing students and all the other allied health students as well as also at the resident level, since we have 1,200 residents working under the University of Illinois training umbrella. where do they fit into the vision
Yeah.
you have for the next few years?
Well, I appreciate that comment. It's a very, very important comment. I think education is, at our institution, is something that needs a very, very bright light shown on it. I think we have some areas of our educational mission that we do really a spectacular job. I think within our residency programs and other portions of our medical education and graduate education, I think there's room for improvement. You know, there's room for improvement in not only the quality of the product that we're delivering at the end of the residency education, but also in the diversity of the trainees that we're sending out. Within the health science colleges, we have discussions around this, and within, particularly, for example, with Dean Azar, this is something that he and I discuss frequently because we have a shared commitment to moving exactly to be as elite and as outstanding in that domain as well. But I think, again, we're in an analysis sort of stage of that endeavor, and I think that what will come out of that will be more focused opportunities for us to raise our game. So other questions here? It's because the wine's right outside the door here. Sure, go ahead.
My name is Sabina Dambrauskas, and I'm a nurse midwife at the hospital. And one of the things, retired now though, I don't see a lot of emphasis on advanced practice nurses, and I think that's, you know, Institute of Medicine has said that's part of the future of healthcare delivery. Care to comment?
Yes, that's a very, very good point. And if I maybe had a 3-hour town hall, I would have absolutely spent much more time on that. What is inevitable and is observed by everyone who's spending time thinking about how U.S. healthcare is being transformed has exactly what you brought up in the center of the crosshairs. New models of delivery, new models of how to produce and deliver care in centers that aren't based on a footprint like an academic medical center. So, you know, the midwives program, a great example of exactly that. So this is not lost on us, and I think this is one of the reasons that I think we have within the health science colleges that we have here at the University of Illinois. It's an opportunity of being innovative. You know, the CMS came out with these Innovation Challenge grants, which I'm sure you're very familiar with, and it's because CMS doesn't know how exactly to identify a model that's best served for delivering care, you know, across the spectrum of care, emphasizing much more the preventive nature and early detection, et cetera. So we're thinking about those, and what we had as our contribution to the Innovation Challenge, Jerry and other individuals in population health sciences with a lot of engagement across the entire health science spectrum there, you know, had a lot of competition for applications to try to think about how do we think about new models. And we submitted 4 outstanding applications. You know, not surprisingly, the funding wasn't as substantial as we thought it would be, and we didn't get one of these. But we are funding these internally to try to think again how to come up with better models. And I think the exciting part here, quite honestly, is the fact that we have a healthcare delivery system. It's FQHC in Mile Square. There's an opportunity for us to look at different components within the Mile Square facilities and compare and contrast what models work best. We can do these, you know, we're academics, right? We do experiments, we can test A versus B. It's not clear what is best right now. I mean, I think that's for sure. But I think we can do the sort of modeling that will allow us to get more information and be better prepared. And with the engagement of all the health science colleges, and in particular the College of Nursing, which has fantastic expertise along this whole area of community-based healthcare delivery, I think that we can come up with some very interesting successes there. But so I thank you for that question, because it's a very important one. And as we think about, you know, the road between where we are right now and 2015, the issue you raise is going to be a very important one that we'll need to grapple with. Other questions, please? Please. No. Well, if not, then I thank you all for being here. And I'm sorry, yeah.
Alamo, United School of Public Health.
Mm-hmm.
So with the push
more faculty to buy into a more integrated health system.
You're in the School of Public Health?
I'm in the school.
And so how do you see that being the direct link to your comments here within your school? Can you help me understand that one?
These are conversations within the School of Medicine, within the School of Nursing. So it's among the health science colleges.
Okay.
And with the push, again, for integration, how do you avoid disenfranchising the faculty and staff?
Well, I think that this is a very difficult time when you have change coming through a university system. That's rough on people. But I think what I am proposing to you is that here's a mission, and through these town hall venues and communications that's been darn consistent over the past time that I've been in this position, we're going in this direction. And will that disenfranchise folks? It might. I think people need to have clarity of thought to figure out whether that's part of a mission that they want to be a part of. And let's be honest, it doesn't appeal to everybody. When the reasons folks came to the university here are for a lot of reasons. I think this mission, however, I would argue that this resonates with the vast majority of folks that are here. And I think it's what our mission is. And so to be part of something that is successful in this domain will be a fantastic thing. It'll be fantastic for the individuals that are participants in that particular endeavor. It'll be fantastic for the colleges that will be the game changers for how this was able to move forward. But it'll also be fantastic for our university because we need a pathway to academic distinction. And I'm telling you, this is it. So, again, it might not be for everyone, and so folks have to make individual decisions about what they want to do with their academic careers. Other questions? Well, if not, then please join us just outside and, a little refreshments. I'll be around, answer questions if you don't want to use a microphone. Thanks.